All right, everyone. Thank you so much. I know there were some technical difficulties, but let's get started. My name is Dan Zumsteg. I'm a fourth-year medical student, and this evening I'll be one of the moderators. Just a few housekeeping things before we get started. Today's session, as you might have heard, is being recorded, and it will be uploaded to the Critical Care Medicine section website within 24 hours of this recording. So if you got any friends that couldn't make it, let them know. There's also, chat. You can ask your questions live on the air if you wish. We want to encourage your participation in whatever way you feel comfortable. If you're scarfing down some food and you don't want to be on camera, that's fine too. This session is meant to be engaging, so let's get started. If you guys are willing, let us know where you're zooming in from. It's hard to know these days where folks are coming from, and we like to reach a diverse crowd. So. City, state, country, institution, let us know in the comments or the chat rather, where y'all are coming from. While you're doing that, I'll introduce some of our panelists. We'll start with Dr. Fred Gamora. He's the Chief Administrative Fellow for the Department of the Surgical Critical Care and Trauma at the University of Pennsylvania. He attended LE-Com Bradenton for medical school and was initially a surgery resident. Then he transitioned to combined EM/IM at Jefferson, and his passion for emergency medicine was obviously the critical care, of course, but more importantly, the airway management. In his free time, he's a weightlifter, and he raises wildlife in the form of two boys aged 2 and 5. As a former boy, yeah, they're pretty wild. Next up is Dr. Allison Hines. She's an assistant professor of emergency medicine at the University of New Mexico, starting in September. Oh, I'm sorry. Dr. Gamora, why don't you hop on, say hi, let the folks see you.
Yep. Hi, how's everybody doing? Hopefully the wildlife comment didn't offend anybody. Anybody that has boys knows it's true, but happy to be part of it tonight.
All right, thank you, Dr. Gamora. So I'm sorry, I was just introducing Dr. Hines. She will be an assistant professor of emergency medicine at the University of New Mexico, starting in September. Her pathway, hi there. Her pathway began with undergraduate and medical school training at the University of Nebraska, then her EM training at St. Vincent Mercy in Ohio, followed by a 2-year trauma and surgical critical care fellowship at UPenn, a lot of Pennsylvania folks. She's most interested in developing her knowledge of trauma and surgical critical care by studying outcomes. And she recently became a pandemic Pelotoner. I didn't know that was a thing. And otherwise enjoys golfing, running, swimming. Welcome, Dr. Hines.
Hello, thank you for having me. Hope everyone's doing well.
All right, next up is Dr. Benjamin Resni. He took the standard, in quotes, path to career in medicine as a zookeeper, turned police officer, turned doctor, and ended up being the perfect, preparation to handle a shift in the emergency department. He's originally a native of St. Paul, Minnesota, did his undergrad at the University of Minnesota, medical school at Des Moines in Iowa, and his residency at University of Tennessee in Nashville, with a fellowship at the University of Iowa in anesthesia critical care. He is most passionate about being there for folks at the worst time in their lives, which is, of course, often the case in the ICU. He's now a full-time practicing academic intensivist and is involved in graduate medical education and is the medical director for the University of Iowa Hyperbaric Medicine Program. When he does have spare time, he's a hiker, a camper, a traveler, and a genuinely cool dude, which with a background like that, how can you not be? Welcome, Dr. Resni.
Thank you. I'm pretty excited to be here tonight too and talk with everybody and answer any questions.
So our last two panelists, I have Dr. David Gordon. He's an assistant professor of emergency medicine at the University of Florida with medical school at the University of Illinois in Rockford, his residency at the University of Maryland, and then a resuscitation fellowship at Stony Brook up in New York, I believe. but he's a glutton for punishment. So he went back to Maryland for a critical care medicine fellowship. And he has a not so wild dog and likes to work out and spend time with his friends when he does have free time. Welcome, Dr. David Gordon.
Hey guys.
And we're very lucky to have Dr. Gordon. He was supposed to be, you were working earlier this evening, weren't you?
I'm working soon. I have to go in tonight. I thought I was working, but it said I'm working tonight in like day 8 in a row.
Wonderful. Well, thank you for sharing your time with us. And lastly is Dr. June Gordon. I actually, unfortunately, I don't have a bio for you, Dr. Gordon, and I'm sorry. Would you mind introducing yourself?
Of course, I think that's my own fault, so you shouldn't apologize. I think the apology should be from me. I'm June Gordon. I did emergency medicine residency at Stanford, where I also did critical care medicine fellowship, where I also practiced as an intensivist in their ED ICU and their MS ICU. And I'm also the associate program director for our critical care medicine fellowship. So I can answer questions on any of those things. Thanks for having me. And I'm sorry I didn't send you a bio.
Totally all right. It's 2021 and we're all here to adapt. So I think the best way to start for everybody listening at home is to get a sense of where everybody is at and what their current practice looks like. So why don't I start with you, Dr. Gamora? Tell us a little bit about sort of your current practice and what you find yourself doing.
So I'm a second-year fellow now at Universal Pennsylvania. So still current practice is just trying to seek permanent employment. But I think the big thing, and we'll touch on it later, I've had a very diverse and not well-pointed pathway of training. It's like now really trying to hone where eventually I want to find an academic job. So really finding where my niche is going to be and what sort of practice setting ideally will provide me the most benefit for the future.
All right, thank you, Dr. Gamora. Dr. Hines, I think I introduced you next. Tell us a little bit about your current practice.
Yeah, so I'm actually in transition. So for those who do the surgical critical care pathway, we end up finishing our fellowship at the beginning of August. And so I'll be starting soon up in September at University of Albuquerque. And that's going to look like I'll be covering all 4 ICUs. And then eventually they're going to be we're working with the American Board of Surgeons and with the trauma department and making everything all ready. So I can also work with the trauma staff and be a trauma attendant too.
Wonderful, thank you. And Dr. Resni?
Sure. So I went to fellowship at the University of Iowa and I stayed on there recently as staff. So I'm a staff intensivist right now in the first couple of months out of fellowship. And so our ICU here looks very mixed. We have a surgical neuro, trauma, everything in the ICU basically. We also have a CV ICU and I work both of those. On my weeks out of the ICU, as you alluded to earlier, I've taken up hyperbarics. So I do kind of a combo practice of ICU and hyperbarics.
Wonderful. And Dr. David Gordon, tell us a little bit about what you do these days.
So I'm also in the first little bit of my my attending life. So what I signed up for is a 50-50 split of EM and critical care because I didn't want to kind of give up what I had spent 3 years doing. And it's both in the community and in academics. And we have a mixed ICU in the community, and then I cover some of the ICUs at night, the variety like academic ICUs, and we'll be getting involved in the ECMO program here when things settle out a little bit.
Wonderful. And finally, Dr. Gordon, tell us a little bit about where you're at.
So I split my time between the MS ICU at Stanford and then our ECC program, which is pretty unique, I think. It between the hours of 2 and midnight in the Stanford Emergency Department, we have a dual trained EM intensivist. And we work both in the emergency department and the ICU, take care of new patients, see unstable patients, things like that.
Awesome. Well, thank you all. So the sort of purpose of this this series of roundtables is to help folks who are interested in going into critical care get a sense for what they need to be looking forward to, what obstacles might lie in their way, and how to get around them. So I believe we had some questions submitted prior to this meeting. One of them I think is probably a good place to start. When do you start putting your application together? Anyone feel confident in starting that one?
I could jump on because I guess Allie and I were actually fellows together, and this was like a personal interest of mine. So I think it really depends on your pathway, and it kind of leads into, I saw the second question, but it depends on what you're interested in. So the uniqueness of emergency medicine, critical care, and I think if the pioneers end up watching this, really has only been a board eligible specialty since 2014, right? So you have your 5 pathways that you go through: neuro, medicine, surgery, and then obviously the traditional routes. So I think it really depends on which pathway, because anesthesia, you're going to be applying and matching at the end of your 2nd year. Trauma and medicine is going to be the beginning portion of your 3rd year or 4th year, depending on whether your program is. And so it really depends on, the hard part is intern year is tough enough, but you should have some inclination that you are interested in critical care, probably your intern year. And really hone kind of what you're looking for. So if you know you want CVICU and you really want to think about the anesthesia route, you need to be certainly earlier. You apply and match in May of your 2nd year or 3rd year, depending on your program. The surgery match tends to be the last one, which is in October of your last year. And this is actually the 1st year that medicine critical care is going to go to a match. And that's totally separate outside of home crit in the early portion of your last year as well. So hopefully that answers kind of the question that you're looking for.
Excellent. Thank you, Dr. Gamora. Does anyone in the audience have a particular question about their pathway into critical care, or about the timeline for them? I know a lot of folks might be sort of curious about how COVID might be impacting things. If anyone does, feel free to hop on. One of the other questions we got is someone who has an interest in combining a great number of interests: surgery, neurology, emergency medicine. I was wondering, David Gordon, I know you have a little bit of a diverse background in that. Do you have any advice for folks that want to sort of synthesize a number of particular specialties?
I think that if you want a kind of a very broad-based experience in your critical care fellowship, I think it's a really good thing to know going in, because it opens a lot of doors. I know that when Maryland was kind of neat, and I don't know if UPenn's the same thing, because we have a whole bunch of people, so they can probably tell us, where we had, I think, 6 critical care fellowships at Maryland. And so you kind of saw this entire breadth of different critical care fellowships and the pluses and minuses and that we all had in terms of getting jobs. So I think the medical people had the easiest time in terms of getting the most diverse sets of jobs. But if there was something specific that you wanted going in, that can really be helpful in terms of helping you pick a fellowship to help you understand that. I also think that if you really want to gain and keep your EM experience and your EM credentials kind of in your EM mindset working, that's also something to look for in fellowship, to make sure that you're talking to those people and say, how did you do that in your fellowship? And does the program do anything to support you when you do that? But if you want to combine everything, you need a program that's going to give you a true, really both breadth and depth in those types of experiences.
Thank you, Dr. Gordon. Any of the other panelists want to add to that?
I think that's absolutely right. And I think that it doesn't have to be the separate pathways that give you the breadth. So for example, our critical care medicine fellowship at Stanford is quite varied. It's interesting at Stanford because we have 2 fellowships that run side by side, an anesthesia critical care and a medicine critical care fellowship, that are quite similar. There are some differences, of course, and if you guys have specific questions, we can talk about them too. But I think if we talk about them more broadly, you'll get experience in our CVICU, in our And our MSICU, which is, largely medicine patients, though some post-op neurosurgery patients, some post-op ortho patients. You'll have experience with our neurocritical care team, with our trauma team and our SICU. So even in the critical care medicine fellowship, you'll get a quite varied experience. So I think it's really, as the other Dr. Gordon said, no relation. It's really fellowship specific.
If I can just add something really quickly. Well, I wasn't saying that you should choose a specific path, just to be clear. I think look for a fellowship where you get that variety of experience. So for instance, like in our critical care medicine fellowship, we rotate in the neuro ICU, the SICU, the MICU, the trauma ICU. We can rotate in any of the other ICUs we wanted. And so we could all do that. Our trauma fellows rotated when they did their ICU fellow training almost only in the CVICU, our VV ECMO ICU, the trauma ICU, and the neurotrauma ICU. And so they got a very different experience, and it becomes kind of hard to fill in those other places. And so when those people were looking for jobs, they didn't have the same places they could apply to, because they weren't, they were like, oh, we're looking for medical critical care people. Anesthesia critical care could be the same thing. And as someone who did a medical critical care fellowship, most closely aligned with the palm critical care people. So then when you're looking for MICUs, a lot of people will want someone, you might have trouble because you don't have the palm that they want. And that can also make the job search really challenging. But I think if you want to combine everything, you need to find a program that is very broad in terms of the training and gives you those options, either by design or by having lots of elective time.
Yeah, I will say, so I think if you want all of those, places like Pitt to come to mind, where it's a single fellowship, multidisciplinary. And I think you have to think about your practice location when you're done. That a lot of the big academic centers still have separate units, and like David said, separate fellowships. And then obviously there's early adopters and not so early adopters of different sideload units. So if you want to practice all those in a mixed med surg, neuro, community hospital, ICU, I think that's reasonable. If you want to be a tier 1 neuro, cardiovascular, pulm, SICU attending, that might be a little bit more difficult to navigate. Not to say it can't be done, but I think it depends on your eventual practice setting that you want. So if you're looking to be world renowned in all 5 of them, that good for you. It just may be a little bit more difficult. But if you certainly want to go to a mixed, like academic adjacent, large, high acuity unit with that background, I think that's certainly doable. Plug for EMIM, because then you can pawn off your medicine boards to get a MICU job.
Yeah, I think everyone's advice has been like really good, but I think also a lot of it's just also about thinking creatively too. And so like the American Board of Surgery says you have to technically do this amount of months over the course of like this year, and this is kind of what your blueprint is. But at the same time, like there's also a lot of like freedom and whatnot. And so while me and Fred were getting our exposures during our first year, we still had a lot of like freedom and a lot of ability to kind of go out and seek out the experiences that we needed. And so if we knew if we wanted to then like apply for like more like a neurocritical care or neuro heavy place, it would be very easy to go get the hours and the amount of like workload that we needed to. And we had a very like supportive program director who's willing to be able to make that happen and be able to make months change and stuff. And so I would say it's a nice balance, or I would go looking for a program that is just supportive and strikes a balance of education versus service, because you kind of already learned how to be great doctors and during like residency training. And so now it's more of, these are your 2 years to kind of like really just develop yourself.
All right, wonderful. As always, if you're listening at home and you have a question or want some clarification from any of the panelists, speak up or drop your questions in the chat. We want this to be, again, interactive. Speaking of, this sort of dovetails with what Dr. Hines, you were talking a little bit about. This is a question from one of the folks at home. Is an away or visiting rotation expected or recommended, and how do you fit that into the timeline of your application?
I don't think it's by any means like expected. It definitely like won't hurt. And if you absolutely feel like you have to go to, I don't know, like Oregon or some like hospital system and that you really want to match there, then that would be a good way to kind of put yourself on display there and to become really familiar with the people. I think kind of the most important thing to kind of do during your couple of years of residency is just to become really great clinicians and then just to be really involved with the people at your institution. And so get involved with the intensivists there. And like those are going to be the people that are going to make writing your letters of recommendation and really pull them for you for your application cycle.
Dr. Resni, any thoughts?
Yeah, I think that varies. Like she was saying, when you're a resident or when you're trying to get into residency, the idea of audition rotations is a big thing. And that's not so much a thing in fellowship. I sit on the committee that selects the fellows for our programs, and we don't really look at audition rotations here. We don't really have them. What that does take precedence is sometimes you'll have internal candidates who are already used to your system, and they may find a way to, have a rotation in the CVICU as one of their months. One of our EM candidates did that. She definitely stood out because most people during their EM residency don't necessarily do a CVICU surgical rotation. But that's kind of a special case. So I would never hold it against you. I don't think our admissions would for not doing an audition rotation.
I'd say for all the residents and even med students out here, I think the hardest part of interviewing for residency and honestly even med school is that you're on the hot seat, and every place you're just basically begging them to take you. I think a really good part about fellowship, and everybody can chime in too, I think it was the opposite, where you're actually on a level playing field. You're a soon to be boarded, graduated attending who can get a real job. So really, as much as it's kind of flipping the importance, you're also interviewing the program, and you can kind of get to pick where you're going to go and why you want to go there. So I don't think you're as much at a disadvantage as you are when you're looking for residency. You're not a med student kind of please begging to come to take me. I think for fellowship, it's much more about mutual, like, is it a good fit for you? Is it a good fit for me? And I think most programs I interviewed really acknowledge that.
More like a job search almost than a residency, because like Dr. Gamora was saying, there's the candidates that tend to go to fellowship tend to be more direct, and I think most end up matching somewhere agreeable to them, whereas residency can be a little tougher match.
Well, it's certainly nice to know that as soon as I get past residency applications, people are going to be a little bit more interested in finding me a place for fellowship as opposed to begging and pleading. So I wondered, let's see here. I wondered, Dr. Gordon, if you could, or sorry, Dr. June Gordon. This is going to catch me more than once. I wondered, Dr. June Gordon, if you have any sort of perspective on this as someone who's been at your institution for a little bit longer. I know that like Dr. Hines and Dr. Resni are fairly new. I was wondering what you've seen in terms of applicants and things over the years.
In terms of visiting rotations?
Oh, yeah, or in terms of like visiting. Yeah, certainly. Like if a visiting.
Sure. I think probably COVID will change all of this. And so for sure, there's no expectation that anyone does a visiting elective. I think most places actually don't offer them. And if they do, in very select cases, and COVID will make it very unlikely for anyone to do them. And I would say, I feel pretty comfortable saying no one will hold it against you if you don't. Probably ever, and for sure now. So I would not spend 1 second worrying about that.
All right. Dr. Gamora, you mentioned something that I wanted to circle back to, and that is this idea of finding a good fit. And for all of you, it seems like you found a good fit at your program. And I was wondering if each of you could talk a little bit about what it was that made a program a good fit for you, or you for them. I think that's something that anyone who's interested in critical care should be thinking about early on in the process.
Sure, I'm happy to jump in. So I think you really need to view your training background. So I did a community hospital residency that was very service driven, taught you how to be a great doctor, taught you how to keep people alive until the morning, but didn't focus as much on kind of evidence-based, study-based medicine. So I think knowing from residency, what was most important to me is I wanted a total flip to academia, protected education time, and less of the kind of service-driven portion. So for me, for fellowship, it actually was really important, kind of going on the lines of they interviewed me, I interviewed them, and heard about like how much didactic time is there, which education is provided, and that was, I think, big for me, knowing what I was looking for. And you kind of have to recognize that as the more protected academic time you probably get as a fellow, that might mean less direct decision making, because you probably have more attending oversight. And they just go hand in hand. And I think you need to know, do you need a place where nobody's watching you most of the time, or do you want some place where somebody may be standing over you, but you're getting maximal education? And I think for me, that was, I flat out asked, to be honest, and every place was pretty honest with me. And I think that's important because it's 2 years of your life that you're doing optionally. You should be happy there, and to be honest, you'll thrive better, and the rest of your program will like you better if you thrive, opposed to feel disgruntled about being there.
Absolutely. Dr. Hines, were you looking for a program where somebody was watching over you, or where nobody was watching over you?
Yeah, it's kind of, or me and Fred, we went to the same training program, so we kind of were looking for the same thing. So I was looking for a place that really wasn't looking out for me or watching over for me. And that was just really great, kind of how, as I alluded to earlier, like when I was like on like my vascular or like X rotation, I was able to kind of go over to other institutions, and because we have several institutions at our hospital, and was able to kind of maximize and go get that type of exposure and experience over there, because I wasn't expected, or I didn't have to be at my home institution, and they certainly welcomed it, and we're all part of the same group, and so like they knew me over there too, so it really worked out well, and also allowed me to be able to kind of take advantage of all the resources within the health system too. Like I was able to take 4 or 5 classes through the college throughout kind of fellowship, which is really beneficial for me in the long term.
Excellent. Dr. Resni, same sort of question to you.
Sure. So I'll give you a full disclaimer here. I was stalking my program long before I applied here. I had been interested in critical care my first year of EM. This will be probably something I'll get into more later, possibly too. But I remember rotating in the ICU for the first time as like an intern and thinking, man, this is just crazy. This is amazing, all this stuff. And then I kind of felt guilty for thinking that, because I didn't think EM doctors were supposed to care about inpatient stuff. And it was like these blocks in my head. But I started exploring that a little farther. And one of my mentors is here. His name is Dr. Nicholas Moore, and he's one of the early adopters of emergency medicine critical care. And he had a great design program in Iowa. And I'm from the Midwest, so I had no qualms about going back to the middle of the country here, kind of the flyover states, and from Nashville. And so at any rate, I stalked them early, and I thought it was going to come across as a little, strange and weird, but he responded right away to me and was very much a mentor from the early days, invited me out to Iowa on one of my trips back home from Nashville to the Twin Cities. And I stopped by and I actually did lunch a couple times, and he helped me through the process of it. But I looked at the program online and saw the way that it was combined with the surgical program here, and how we had a wide variety of experience. Like somebody was asking earlier, we don't have a lot of separate ICUs. It's all combined into one. And I just really liked the structure, and I thought I would be so lucky to match. But like we talked about earlier too, you start to find out through the process that actually, if you show interest and you like a program, we are interested in getting the people that are interested in our program. So it's a whole different experience. So yeah, long story short, I had a little bit of a stalker background on the critical care programs, but I've recovered since.
Very, very happy to hear about your recovery. Dr. David Gordon, did you have eyes over you the whole time, or people would just leave you alone?
So that's a great question. For our institution, it was very unit specific. So if you're in the MICU in Maryland, you had eyes on you pretty much the whole time. There's attending in-house 24/7, sitting in the office. They were with you on rounds. So you have pretty consistent oversight. When, like we talked about before, you do a variety of rotations and you work in a bunch of different units. So in some of the units, I rounded on my own with the APPs, and they presented to me like I was the attending. And then I would, circle back with the attending later and be like, hey, these are the things I did. For in other units, there wasn't an attending in-house, and you know, I did what I wanted to do. And in the morning, they'd say, gee, why is everyone on ketamine? And so it really, for us, it was just very variable. I think the things that you have to look for first and foremost is you have to find a place where you get along with the people in the program. You guys are, I don't know, because I haven't had to do a lot of big interviews. I guess I interviewed for my job during COVID, and I felt like I got a pretty good sense of people, but you guys will have to figure that out for as you interview for programs, if you feel like you get a good sense of those things. But I think that's probably the most important thing. And ultimately everything else will work out. There will be attendings that you like and don't like and things like that. I can tell you when I was an intern and rotated in the MICU, I had the opposite experience. My attending made me cry. I got in trouble with my program director. It was a really big problem. And I was like, oh my God, maybe I won't do critical care. And then my mentor did this fellowship and he kind of talked me into it. And that was pretty much that for me. So you just find a place where you like the people, and that'll be the most important thing.
Kudos for being a brave person that said you cried as an intern.
Say that again.
I said kudos for you for being a strong human being that said you cried as an intern.
We all did it, just some of us are willing to admit it.
If it happened behind a closed door, it never happened.
Oh, it happened in front of my program director and then in the MICU. In front of everyone.
Come for the critical care advice, stay for the therapy. Dr. June Gordon, any final thoughts on sort of whether a program, like the program's level of oversight, or what you think is helpful?
I think we've been sort of sidling up to the answer to like the big question, which is, I want to do critical care and how do I do this? There are so many options. There are so many pathways. When do I apply? What kind of a program do I go to? Which I think is really everyone's question. And I think that there's an important sort of branch point that everyone has alluded to when they answer that question, which is, do you know where you want to be? Right? Do you know where you want to practice? Do you know what kind of unit you want to practice in? Do you know, I live here and I want to live here forever. I only like academic institutions, right? Like I only like surgical patients. Like if you know the answer to that question, be it geographic, patient specific, academics, community, then I think that you should tailor the answer to that question based on that. If you don't know the answer to that question, then like the world is your oyster and there's really no way to make a mistake, right? Find a place that makes your heart beat. Find people that make you happy, because this job is hard, but this job is so fun. And what you'll see that connects all of us is we live and breathe for this. We love this. We love critical care. We love the pathophysiology. We love the patients. We love our colleagues. Like this is what we love to do. And find a place that makes you feel that way, because there are many of them, right? We all did this differently in different places, and we all love it enough that we come here after work to talk to you about it, right? And that means something worked.
I like that sentiment. Find something that makes find a place that makes your heart beat. And Dr. Gamora, I see you in the chat adding, don't feel bad if you don't know yet. I was curious, just for my own edification, like when was the moment for you, Dr. Gamora, where you were like, critical care is for me?
I mean, I think the unfortunate like running joke is now like EMIM, it's just like Kool-Aid, right? Like you do EMIM and then you do critical care, because that's what happens. And I think I took the both portions of the acuity of the ER and the kind of longitudinal of medicine, and critical care just made sense, right? Like we're all ER doctors. I like to intubate people. But then it's kind of sad when I don't get to adjust their vent later and respiratory comes and yells at you. So for me, it just made sense, right? I got to intubate them, and then I get to manage the vent as they leave the ER. And then honestly, the next day, the same way as it did, I was a COVID attending for a while. I graduated early. So I was an EM and IM attending only during COVID, which was glorious in so many ways. But the same way, right? Like I'd see you for COVID, tell you everything was be okay, and then I'd be your medicine attending for the next week and feel bad about it. But I think critical care just made sense, right? It combined a lot of the two residencies together. And for me, it was just it made sense. Like it was always the acuity. In the ER, you like the high acuity. I wasn't a big fan of fast track. I think I knew that from the get-go. So I think it just clicked for me probably about my third year, when I realized that I was supposed to read things. It kind of clicked together.
Dr. Hines, how about for you? What was the moment where you're like, this is what I want to do?
Yeah, I probably actually came to it late because, going to a 3-year residency, and as we alluded to, the applications cycle starts up November of your second year. And so it's probably like October or so of my second year of residency where I actually became interested in critical care and was really on the trauma, surgical, ICU type month. And kind of just as Freddie alluded to, just having the kind of the daily interactions with the families. And it's a pretty wide breadth of patient population. We have a lot of young people, but we also have older people, and just kind of being able to help them and see them from day to day and whatnot. And so it was really cool. I remember sitting at the end of October, November, and trying to figure out what even pathway to go into, with the anesthesia pathway opening up like that month or so. But at the end of the day, kind of as Fred had talked to about the backgrounds, is you can kind of make most of them line up. And so if you don't know, that's okay to apply to several different specialties or several different pathways and then figure it out at the end, because you'll end up getting your interview invites and you'll be going on the interviews. And then if you decide in like April, May, or June, then that's okay. Then you're kind of set up for all the different pathways too.
Thank you. Dr. David Gordon, did you have a moment of enlightenment where you realized critical care was the thing for you?
Yeah, so I actually kind of did. So I already alluded to that I had a rough time in the MICU when I was an intern, and I really didn't like it. And I had a mentor who was our attending during my second year, and kind of, I think, as Fred alluded to, is when he said, "Oh yeah," as I started reading more, I found that as I started reading, and like, what were the things I read? What did I like reading? What did I like thinking about? What was the stuff that I would go home and just be like, this is really neat, and I'd get really excited about it. It was all geared towards critical care literature and just thinking about the physiology and those types of things I found totally fascinating. And then in third year, I was rotating in our trauma ICU, and I just kind of had this moment of panic because I had already agreed to do this recess fellowship, and I was really excited about it, and I had already planned on it. And it was a really great experience, but I was like, oh man, maybe I like critical care actually. And I had a very distinct moment. I can even remember the fellow I was watching where I was having trouble with a central line. And I remember calling one, because we rotate in the trauma ICU as our third year of EM residency as fellows, but then there's actual trauma fellows who are usually also in the unit or on one of the other units. And I was having a lot of trouble with the line. Not that I hadn't done tons and tons and tons and tons and tons of lines as an EM resident, but I was having trouble, and I called one of them, and I just remembered watching them do it, and I went, gee, they look really comfortable and not at all nervous about what's happening right now. And I was like, I really want to feel that way. And it all just kind of was like, this is going to be more training. But I'm really glad I did it, and it's super neat. And some of my most rewarding experiences are when I've done kind of just like Fred said, like stuff on the vent and seen someone get better, and you're just like, that is so cool. So that was my personal moment.
Awesome. I love to hear that. Dr. Resni, sorry, go ahead, Dr. Gomorrah.
I was just going to say general caveat too, for I think especially since EM folks, critical care is a relatively new pathway, and those, honestly, the generation of medicine before us fought tooth and nail to even be board eligible to do it, that I would say most EM critical care folks are just so excited that you're interested in EM critical care, that they're very interested in mentorship. And there's honestly enough kind of recognizable names in critical care that it's a young enough specialty that those names are still very willing to talk to you. And if you reach out and say, I'm interested in EM critical care, instantly that pathway contact leads you to 9 different other people. And I've very much had that experience over the last 2 years, that you meet one person nationally, and they're like, I know this person who's interested and this person who's interested. And before you know, you're like circulating, your name is circulating around to former SCCM presidents at other institutions. Just because I think EM critical care people are so interested in getting more EM folks recognized and advancing our specialty. So I think it's a really great time for people to be interested and just reach out. And it's all about kind of who you come in contact with and who you know.
And also, I think EM critical care, as I have figured out over the last couple of years, is a pretty small it's a pretty small slice of people still that have done this. And so we all know each other, or at least know someone who probably knows someone. I mean, I got the job I have now from like 3 different people, and then I got down here and they all know all the people that I already knew. And it was weird talking to like one of the guys here who like trained with all the people I knew, but he trained with them instead of had them as attendings. And so, you know, we all, it's a really, really, EM is a small world. And then this is even a smaller world. This is one cherry in the entire cherry pie of emergency medicine.
That's a wonderful analogy. Folks in the audience, any burning questions? We've got about 10 minutes left in the hour, and I want to make sure that any questions from the audience are answered, or any concerns or things are voiced.
I had a question. First of all, my name's Colin Walter. I'm a second-year student out at ATSU in Kirksville, College of Osteopathy, and basically, where I come from, a small town, I've been involved with EMS and fire before I came here. I've had no family members who are doctors, so I don't have like any mentorship or, you know, someone who's just like, yeah, you do this, this, and this. And so basically I have no idea what's going on, and I feel bad for asking this, but it sounds good from hearing that you guys basically say, you know, applying to fellowship and there being a match, it's almost like doing a small job search. Because before today, I didn't realize there was a match for fellowship. Like I said, I know nothing. But one thing I did want to ask was, in terms of what is like the, I guess, in the difference in day-to-day life between residency and fellowship? Because to me, from an outsider perspective, since I don't know much, it seems like with residency, you're within, because I'm interested in EM. So basically I'd be, you know, a resident as emergency medicine. And then if I went to go do fellowship, I guess if I wanted to do, you know, critical care fellowship, I would do almost like your 3rd and 4th years of med school. You do like rotations in different parts of critical care. Is that correct? Or how would that, you know, work?
It's actually the most awesome change in the world when you go from residency to fellowship, and then you figure out when you become a new attending, it's even better yet. But there's a lot of differences. So in the resident world, you start off your very first shift, and it's going to be overwhelming your first year, and everything's just crazy. I still remember, you know, one of my first patients was a massive head bleed, and I had to call a neurosurgeon on my first day, and I just blabbered everything about the patient being a diabetic and everything else I didn't really care about. So you learn pretty quickly, like from the bottom of the line there when you first start, on how to do all the basic stuff. But as a resident, you know, you're doing a lot of the seeing patients, getting as much experience as you can, doing all the basic groundwork. When you become a fellow, you start to taste almost like a junior attending. You get a little taste of like a junior attending, where you have a little more of a supervisory role. Like when our fellows start here, they've been here maybe a month now, it's, you know, mid-August, and they are now responsible for not only the residents, but the medical students on the unit as well. And they're responsible for kind of running their piece of the ICU. In our case, it's a small, you know, a 12-person bay or whatnot. And the fellows report directly to the attending each day. But when I come in the morning, you know, I pretty much give the fellow enough leeway that they have already talked to the residents, kind of pre-rounded all the patients. They know where the problems are. They may have even addressed the problems already. And then when we start rounds, I let the fellow run the rounds. And again, you can kind of see where everybody fits into that hierarchy. There is the resident went and did all the hard work in the morning and saw everybody and got all the labs, presented to the fellow's making decisions. And then as the attending, we're just kind of overseeing it and redirecting the ship. But it's a big change to go from residency to fellowship. I would say I'm just out of fellowship, you know, a couple months, but I would say that was a nice step for me. It made me feel a lot better because, like Dr. Gamora and others have kind of led to earlier, it allowed me to study the academic side a lot more, not be worried about all the individual day-to-day work quite as much. So there's a huge difference, but I'd like to hear the perspective, I think, from some of the current fellows, because they probably have a much more battlefield view right now.
I guess is the only current fellow, I'll jump in. But yeah, I think every year, kind of the hard part with 3-year residency, you compare it to some of like the longer residencies, you have this longer time to transition naturally from kind of the junior level learning process to the senior level learning process, and kind of absorbing that, absorbing the good and bads with that, right? I think complications happen. And I think as a junior, you feel bad because you directly feel like maybe something you did impacted that. Whereas especially even as an EM3, you see like your decision making in the higher level processes. I think you feel like a higher level of guilt when something goes wrong. So it is really nice to kind of some of the classic quote unquote scut work. You're not writing pre-rounding, writing notes and repleting lights. So that certainly changes, but you have a lot more time to think about like the big complex decision making. But I think I also, while it's a lot better to make that higher level decision making, I think I truly feel worse than I did when I knew I was just like writing notes and repleting potassiums, and probably what I did didn't change things, to where now I've decided to make a whole level of extubation plans, and then the tube comes out and it instantly fails, and you know that that was probably totally on me. So I think it's both a double-edged sword. It's great to make good decisions and be able to make those decisions. But it comes with a double edge of knowing that I definitely inherently feel more guilt when it is not the correct decision.
I think just the experience of being a fellow, it is definitely a big change, and you get kind of more responsibility from a global standpoint. The thing where you don't have to replete the lights and write the notes is not always so true. Like I said, we had a bunch of different programs at Maryland, and our surgical fellows, you know, when we did their rotations, we called it like res interning or like res fellowing, because you pre-rounded and you presented, and well, we had order sets, but like you'd still replete the lights and you'd still get woken up at night for the potassium of 3.4 that you had to do, and you still wrote notes. So depending on what you want, it might be different at different places. I think one thing that changed really for me that I had to get used to going from residency into fellowship was EM is this specialty where you're like on a couple days and then off a day, and on a couple days and off a day, and you may work in the morning and then you may work in the afternoon, and you kind of have this schedule all over the place. And then you can work different things that you need to do into your life, because usually at some point in the week you'll have a Monday, you know, you'll have a 9 to 5 period off if you have to go do something. In fellowship, you know, a lot of times you worked every day, at least we did. And so there was I might not have been there as long every day, or my life may have not been as high energy every day that I'd have to do. But I had to still do the same, like life still goes on. And if you only have a Saturday, like 2 Saturdays off in the month, or like, you know, 3 Saturdays or 2 Saturdays and a Saturday and a Sunday, it's kind of hard to fit life in at some point along those things. So it just kind of depends on what you want and what you're looking for. And some fellowships will be like super hands-on and you have to make all the decisions, and some will be like you're still going to replete electrolytes.
Dr. Hines, you've recently transitioned from being a fellow to now an attending. Any thoughts about the change in responsibility, change in workload? What have you noticed?
Yeah, I think for me, probably the most difficult thing that I'm gonna have to do, and we kind of got a taste of it in fellowship, because in fellowship there'd be kind of, as Dr. David Gordon was alluding to, that the different units look different, and so we had some units that were solely APP based, like our trauma surgical unit, and then we had other units who were solely resident based, like our surgical critical care unit, and it was mostly junior house staff. So similarly, I think the most difficult thing for me transitioning from a fellow to like an attending will be just kind of knowing how much of a leash to give people, and knowing just how to be able to overlook someone. So that way I'm always anticipating their missteps, but also allowing them to kind of take ownership and allowing them to take control and get the growth that they need, and to be able to really thrive too.
Excellent. Dr. June Gordon, final thoughts? I mean, I think we've heard quite a lot, but I wanted to give you an opportunity to sort of expound.
I think final thoughts in general are that this is a really small world, and it's a really wonderful small world of EM critical care. And, reach out to us. We are here. If you have questions, ask. This is a really exciting, wonderful specialty. It's a lot of work. It is full of people that are trailblazers and people that have chosen that because this is new and young, and you'll be the first person doing what you're doing from your medical school and from your residency and from your fellowship and where you're working. Like, you will be the only one of you. And hopefully that will be less and less as you get there, but just know that that is how this is. But it's really excellent and worth it. And ask lots of questions and take advantage of the fact that there are some of us that have done it before you.
So we're reaching the end of the hour, and Dr. Gordon put into the chat a shameless plug, of course. There's a mentorship program within the critical care medicine section. Colin, I encourage you to reach out to us and apply to be a mentee. Certainly, it's a wonderful chance to get some advice early in your career, especially if you want to go into EM and critical care. But just in general, our critical care section is a very welcoming group. If you're interested in learning more, of course, our next council meeting is on Thursday, the 2nd of September at 7 p.m. Central Time. If there's a topic you want us to cover, if there's something you want to know more about, you can always add it to the chat box here, or you can send us an email at info@aaem.org. It looks like a lot of the panelists are adding their emails. If you have a specific question, of course, reach out to folks. Nobody's more excited to talk about their field, I think, than critical care physicians, because they're just so excited to have somebody else to talk about papers and studies with. We invite you, of course, to join the critical care medicine section if you haven't already, and you can learn more at our website. Thank you all so much for joining us tonight, and we look forward to seeing you again soon. This ends the webinar. If you have anything else to ask, of course, feel free. Otherwise, have a wonderful night.